Welcome back to my channel for another video on device closure of atrial septal defect. Before going into device closure, we learned a little bit about different types of atrial septal defects and view a few images on transesophageal echocardiogram as well. This is the right atrium, left atrium, superior vena cava, aorta, main pulmonary artery. Mitral valve, left ventricle, right ventricle, tricuspid valve, interventricular septum, and this is the defect in the intraatrial septum and depicting the left to right shunt across the interatrial septal defect. This will roughly correspond to secundum type of atrial septal defect, which is the one most often closed by device closure. Shows the various types of atrial septal defects. These two are sinus venosus types of defects. This is the superior or the superior vena cava type of defect. This is the inferior or inferior vena cava type of defect. This is the standard secundum ASD in the middle, fossa ovalis type of atrial septal defect. And this is coronary sinus defect. Near the inferior vena cava defect, you can have a coronary sinus defect, that is near the opening of the coronary sinus into the right atrium. And this is primum atrial septal defect. We know that primum atrial septal defect is part of endocardial cushion defect and can be associated with tricuspid or on the other side mitral regurgitation. Before proceeding with the device closure, an excellent image of the atrial septal defect has to be obtained using transesophageal echocardiography. In transesophageal echocardiography, as the transducer is very close to the left atrium in the esophagus, higher frequency imaging with better resolution can be used. Another advantage is that in transesophageal imaging, unlike transthoracic imaging, lung doesn't overlap the heart, so excellent echo window is possible in transesophageal echocardiography. Only disadvantage is that it is semi-invasive. There could be some discomfort during the procedure, which requires careful monitoring. And the probe will be here. This is the aorta cross section. This is the intraatrial septum, because probe is in the esophagus just near the left atrium. This is right atrium. This is part of the intraatrial septum and the aorta. And this is the atrial septal defect. Here you can see that the aortic rim is deficient, which is often there. It may not be an absolute contraindication. We'll have to look at other rims which can hold the device in situ. If the device does not hold well, it can get embolized and require snaring or other procedure to retrieve the device which has embolized. So this is a transesophageal echocardiogram. This is another transesophageal echocardiogram. Difference is that you have two atrial septal defects, 1 and 2, and the measurement has been shown in the figure. This portion will be the left atrium. This is the right atrium. This is not the same view as this. There is some difference, and it is not the same person also, different person. And you have two atrial septal defects with a small amount of atrial tissue in between. The first one measures 1.75 centimeter and the second is 1.56 centimeter. Such type of atrial septal defects will have to go for surgery because it is rather difficult to close such a large defect, and the two defects together. Device closure of ASD is suitable for secundum ASD with a good rim all around for holding the discs together. Transesophageal echo is done to assess the superior aortic and mitral rims as well as the total septal length. It is ideal to have TEE guidance during the procedure as well. A guide wire is introduced through the femoral vein into the inferior vena cava and further through the right atrium across the ASD into the left atrium. The tip of the wire is then placed in the pulmonary vein and a long venous sheath is introduced. Once the sheath is in position, the device attached to the delivery cable is introduced into the sheath under water to avoid air bubbles in the system. Bubbles in the system can get embolized during delivery with air emboli going into the systemic circulation. If it reaches the cerebral circulation, transient giddiness and altered sensorium can occur. ST segment elevation and hypotension may occur if the air bubbles find their way into the coronary circulation. Oxygen inhalation and other supportive care usually takes care of minor air embolism, as the manifestations are often transient. Once the device reaches the left atrium, the left atrial disc of the device is released first and brought in contact with the left atrial side of the ASD. When the position is judged ideal, the right atrial disc is allowed to form by withdrawal of the sheath. Once the two discs are in position with the waist across the ASD, slight wiggling is done to make sure that the device is perfectly fitting and has no tendency for dislodgement. Position is confirmed by transesophageal echo with special care to see that the device does not interfere with the function of the AV valves. Once everything is fine, the device is released by unscrewing the delivery cable. An unstable device can occasionally get dislodged either into the left or right atrium. It may be possible to snare out the dislodged device depending on the position where it gets lodged. Rarely, surgical intervention may be needed to retrieve a dislodged device. One of the dreaded long-term complications of ASD device closure is aortic erosion, which is more likely to occur if the aortic rim is deficient. Fortunately, it is very rare due to precautions at the time of device implantation and pre-implant assessment. A study published in Circulation in 2016 documented 125 cardiac erosions over a period of 12 years from a database. Erosions were diagnosed over a median of 14 days after the device closure. Deficiency of aortic rim was found to be almost universal, while deficiency of any of the aortic superior vena cava or inferior vena cava rims were the most important risk factor for cardiac erosion. It was a case-controlled study with age and sex matched controls. Device oversizing also contributed to the chance for cardiac erosion after ASD device closure. Those who died of cardiac erosions were more likely to have aortic erosion than the survivors and an oversized device. Though the median period was 14 days, 16 of the 125 erosions were diagnosed after 1 year. Other factors related to erosion were larger size of the ASD, larger size of the device, smaller weight bar device size ratio, and more than 5 mm difference between the ASD size and device size. Generally, closure of ASD is done in children and young adults. A study involving 23 patients with ASD and median age of 70 years having ASD size between 9 to 30 mm reported favorable cardiac remodeling and improvement of functional status. The New York Heart Association functional class improved in 16 patients. They had significant improvement in 6-minute walk distance and mental health score. No major complications were noted in these ASD device recipients. They also had significant change in the left ventricular end diastolic and end systolic dimensions at 1 year after the closure. There was accompanying significant reduction in right ventricular end diastolic dimensions as expected. The improvement of LV function was due to offsetting of the reverse Bernheim effect, in which RV dilatation causes a septal bulge and impedance to LV function. Though some studies have shown transient increases in left atrial pressure and consequent pulmonary edema in elderly patients after ASD closure due to a stiff LV, the current study did not report any such instance. The authors concluded that ASD closure with devices is technically feasible and is associated with favorable cardiac remodeling and improvement in functional class in older patients. Here are some important journal references.